this week on the BackTable podcast.
The whole concept of cryoing for pain, I think is, I feel like I was able to bring that here, and we're still developing it, trying to get, everyone interested. So that's really been something enjoyable that I learned quite a bit about it at Emory with Dr. Prologo. The genicular thing really is just at one particular area. We've had a lot of good luck with, for instance, palliative care in the hospital with treating a lot of cancer-related pain.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief word from our sponsors. Today's BackTable podcast is sponsored by Boston Scientific Interventional Oncology and Embolization Division. Boston Scientific Interventional Oncology and Embolization is a global provider of medical devices. Boston Scientific's goal is to become the leading partner by enabling and developing minimally invasive procedures. Boston Scientific recently received 510(k) approval for expanded indication of the visual ICE cryoablation system for palliation of pain associated with metastatic lesions involving bone in patients who have failed or are not candidates for standard radiation therapy. As the only manufacturer with this indication on label for cryoablation in the United States, Boston Scientific remains dedicated to supporting the further growth of cryoablation technology in order to provide expanded treatment options for patients. Now, back to the show. This is Michael Barraza recording in Baton Rouge, Louisiana. I'm honored to welcome Dr. Aron Chary with Vascular Interventional Physicians in Memphis. Thanks for joining us.
Yeah, Michael, thanks for having me. I'm excited to be on and get a chance to hang out with you while we're both on call this weekend. So.
Yeah, we both got killed last night.
Yep, we did, but that's okay. We got a little break here, so.
Yeah, you had two embolizations last night?
Yep, two embolizations, and looks like a few more piling on for later. So
I got
if I get up and run out, that's why.
I get it. I had a stroke and a trauma, and so far it's been quiet this morning. I'm scared to use that word, but today we're talking about cryoneurolysis for pain interventions for benign and malignant conditions. And before we get into that, I want to talk with you a little bit about your practice. Tell me a little bit about where you work, the structure, and what things have been like for you there.
Yeah. So I am in Memphis, Tennessee, in an independent private practice group called Mid-South Imaging, and sort of our interventional subsidiary of that is Vascular Intervention, Interventional Physicians. And we're a mid-sized private practice group. There's about 8 interventional radiologists, and we cover a hospital system really within Tennessee, Mississippi, Arkansas, and throughout other areas of Tennessee. And we also have 2 OBL setups here where we do outpatient cases in clinic. That's kind of the makeup of our group here in Memphis. So,
how do you guys split the cases between the hospital and the OBL? And do you work at both?
Yeah, we do. We all kind of rotate through both. Within the hospital, we're doing the basic hospital cases that you would see, servicing the inpatients and higher acuity cases and things like that. We have a pretty active and busy clinic. And so within our OBL space, we get a lot of referrals, and we're seeing patients in our clinic and kind of managing them through time. And that's really where we're doing more of our elective work. And so, like anyone else who works in a hospital, it's incredibly challenging, even more so in this day and age, to do elective outpatient cases in the hospital. I think that really has defined the need for some of these outpatient facilities for so many reasons. But what I've noticed since I've been working in OBL is the patient care is exceptional.
I'm sure.
And it's just so much nicer for them, for us, to really treat these patients efficiently in a timely manner. They're much more comfortable, and you can get a lot more done.
I bet. How long has your OBL been open?
So I joined the practice in 2021. I think the OBL had been open for about a year and a half prior to that. And so it's really grown quite a bit. We had, one of my partners, Henry Dalsania, who was really our innovator, as far as that goes, had proposed this to the group, and they sort of took a chance on it. Just like any other practice, it's a lot of uncertainties, and it really took off immediately. It was a gamble, and it's been a success ever since, and we've grown immensely. Now we're in our third, fourth year, and really seeing a lot of patients. In fact, we've opened a second OBL in our Mississippi area that is underway now with clinic, and we'll be opening our actual procedural rooms here later this year.
That's awesome that, you have the type of practice where, taking a risk like this is supported by, a combined IR-DR group.
Yeah, it's definitely unique in that we get a lot of support from the group as a whole. And, I think that's because we've done well for the practice. We've established the need for the community. I think our value has sort of shined that way. And so our DR colleagues are really supportive of it. They want us to go out and practice build and promote IR. We've got a marketing team. Then we're out there in the community with, commercials and brochures and events and trying to create this awareness. And it's nice to be in a practice that supports that and is not just, you guys got to just stay on the list and read. So I think it's a unique situation, especially with all the hot debate and topics about various practice models and IR and DR and, independent IR and things like that. I think it's a sort of a unicorn, if you will, of private practice groups where IR and DR really mesh well together.
Yeah, I am in a group where IR and DR work well together as well, and it certainly changes that conversation for me. The all IR, all DR side. That argument is different for me just based on my own experiences.
Yeah, no, I completely agree. So, and prior to coming here, I've had a varied experience from the onset of graduating and coming out of training. We were talking earlier, you and I were both in practices in Nashville, and that was a much different experience for me.
Yeah, me
as
too.
Far as, IR and DR in a private practice group, and, really wasn't exactly what I was expecting or looking for, and kind of learn as you go. And ultimately, it sort of led me to my next chapter, which was joining up in academics at Emory University. And so had the opportunity to have that whole academic experience of IR, where you're doing 100% IR, all kinds of crazy cases all day long. And that was enjoyable. I learned a lot. And really all that kind of led me to this current practice, especially with regard to pain intervention. We'll get into that later, but it's definitely shown me different aspects of academics and private practice and just really what you can do almost anywhere you go.
So, you talked about your time at Emory, and that's really where you got, your start with these pain interventions, or at least certainly that's where you built a lot of the base you're using now.
Yeah. When I was in Nashville, we did do a lot of MSK type pain procedures, injections, ESIs. We did some spine work, kyphoplasties.
That sounds just like my old job.
Right.
In Nashville.
Right. A lot of joint injections, SI joints and various, shoulder, hip, what have you. So that was really the first time I got familiar with that type of work. I had done some in residency, really hadn't done a lot of that in fellowship. And so I got more savvy with sort of that bread and butter type intervention. And then when I went to Emory, of course, I had the opportunity to work with David Prologo out there, who really changed my whole perception of pain intervention with everything that he was doing. And you guys had him on the show a while back, and it was a really great podcast and insightful. And fortunately for me, I got to be there firsthand to work with him and learn from him. And that was, the first time I even heard the word cryoneurolysis.
Yeah. And
so really everything I know and do now was influenced from, his teachings and his mentorship. And I've been able to extrapolate a lot of that into our current practice.
So when you took your job in Memphis, was there much being done in the way of pain interventions?
Not a whole lot. The group really was doing a lot of, PAD, venous work, and really everything else. But I think the one area that was lacking was in the pain realm. And even, injections and things like that, we weren't doing a whole lot of. But, we had a fairly robust oncology service. And, we had a lot of patients with metastatic disease and, various mets to bone and spine. And so there were a lot of these patients out there that, had these pain syndromes that really weren't recognized or weren't having interventions sort of made aware. And I think that gave me an opportunity to come here and start, advertising that we can do some of these things. The group I'm currently in has a very solid relationship with orthopedics. We do a lot of the MSK diagnostic work, and that led to a lot of opportunities for non-cancer related pain intervention as well, beyond just the injections and joint interventions and spine work. And so, as we'll get into in a little bit, this practice has really afforded a lot of opportunity for, both cancer and non-cancer related pain interventions with a lot of interest and support.
So how did you, start building this? In particular, how did you get the word out to these different doctors that, look, I'm here. There's a lot that we're not doing that we can be for pain?
Yeah, that's always a great question. I think back on it and I try to remember specific instances. One example that comes to mind is with our orthopedic surgeons, which we have a really close relationship with through our, kind of MSK radiologists. And, there were a couple of instances, we were starting to do some genicular artery embolization. That was something we had done a little bit at Emory. They were doing some here when I came. And, it was just an interesting service line. I think a lot of folks are really trying to understand it and get more into that. And there's certainly some good data that's starting to, unfold as well. And so we would go to our orthopedic colleagues. In fact, our OBL and office is in a building with one of our ortho conglomerates here that we work with. They're just downstairs. And so
Nice.
We would go down there and, market to them and say, hey, do you guys treat knees? And of course we know they do. And they did. And so, we kind of pitched some of these interventions like genicular nerve block and ablation and genicular artery embolization. And we said, we could definitely try to help you guys out and collaborate. I know that there are patients who potentially are not operative candidates for a total knee arthroplasty or that need to potentially get to a point where they can have one if it's, physical therapy, losing weight, things like that. Or even, there's always this handful of patients that have had a total knee arthroplasty that just have not received the pain relief that they were wanting. And so, our kind of pitch was, hey, we can help with some of these patients. And it is not a competitive service line whatsoever. I mean, these guys do a lot of knees and they have a lot of patients that still have some pain, or of the hundreds and hundreds they do, even the handful tends to be a big volume.
Yeah, that's been my experience too.
And as soon as we said it, they were like, yeah, where do we send them? And so, we started doing a lot of knee intervention, and I can kind of tell you a little bit later sort of how that algorithm has unfolded for us. We're still trying to work through it.
I'm making my way through my own algorithm. I'd love to talk about it.
Yeah, and it's been a great service because in no way again is it competitive whatsoever. I mean, they love this. It's
great.
They failed injections, they failed conservative management. They this is just another option. And so I had one surgeon who does a really high volume of total knees, and this is out at one of our peripheral sites in the hospital. And I was talking to him one day, just randomly in the hospital, I think in the doctor's lounge, and sort of pitched this idea. And, he sent me a couple patients. We did a nerve block, good response. We did the genicular cryoneurolysis, and the first few had incredible response. I mean, just pain-free, went to physical therapy, rehab, recovery, did great. After that, this one physician just started sending, in 3 months, he sent 85 referrals.
God.
And so, it really overwhelmed the system. And I tell people too, that's another thing. Sometimes you got to be careful. If you open these floodgates, you can definitely get overwhelmed with just a large number of patients.
Yeah.
And we were at one point for a few months when we were doing 3 to 4 of these knee cryos a week out there. It put a blip on the hospital radar. They saw this sort of, on their, they don't pay attention to IR all that much.
Right.
All of a sudden they see this capital cost blip on their, the CFO on their map of all these probes being used. And it brought some attention because we were doing a lot of cases, and we were doing a lot of genicular artery embolization as well. So we really had this bustling knee program I can talk more about later, but that was just at one site. And so to sort of answer your earlier question, that was, how we kind of got into this sort of non-cancer related joint pain with knees, and have started to build that service line. And two, we've gotten my partners involved in that. So now they're doing knee interventions as well. And they really weren't doing that prior to. And so that it's been nice to kind of all work together to offer that pain service and try to figure it out.
So the pain stuff that was getting done already, I know you said it wasn't too much that was getting done in the way of pain interventions, but were they using cryo?
Not particularly for pain. They were doing a lot of cryo for, renal mass ablations, some liver, things like that, but really not for pain. So the whole concept of cryoing for pain, I think is, I feel like I was able to bring that here, and we're still developing it, trying to get, everyone interested. So that's really been something enjoyable that I learned quite a bit about at Emory with Dr. Prologo. The genicular thing really is just that one particular area. We've had a lot of good luck with, for instance, palliative care in the hospital with treating a lot of cancer-related pain. Just yesterday evening, when we were chatting, I was just finishing up a celiac plexus cryo for, intractable abdominal pain from pancreatic cancer. And so we're seeing a lot of hospital patients now. They're consulting us. They're becoming more aware of these patients who are just unable to get out of the hospital, whether it's from, metastatic disease, soft tissue mets to the pelvis or abdomen, or spine disease, or intercostal neuralgia, or, various etiologies. So that's a whole nother area that's really started to develop for us in the pain realm.
So this is going to be kind of a tough question because, I know you said this is still developing, but I'm curious where all you're using cryo. Just for full disclosure, for me, I've only been doing it for pudendal neuralgia. I've done one intercostal and then the occasional bone tumor in addition to, other cancer ablations. But for pain, that's really all it's been for me. I'm using RFA for the genicular nerve ablation.
Yeah, probably the most common areas that we use it for, I would say if we're kind of breaking it down into cancer versus non-cancer, for a lot of the non-cancer stuff, we're doing a fair number of genicular, like I mentioned, pudendal nerve, some stellate ganglion. We're doing a little bit of that work as well. I know you guys had Alex on not too long ago, a great podcast about stellate ganglion. We were doing a lot of that at Emory, and it's kind of where, again, I got bold enough to even want to try that here. And so we're doing some of that, intercostal nerve, ilioinguinal, genitofemoral for inguinodynia. We will see some occasional phantom limb. I've tried to create some awareness for that, and we'll see, a few here and there. It did a recently a desmoid tumor that was sort of encroaching on occipital. It was like a head and neck desmoid that had some occipital encroachment on a younger patient. And so benign or somewhat malignant soft tissue tumor type etiologies. We will do a fair number of celiac interventions, mostly malignant, but some non-malignant. Recently, just a few months ago, had a younger female who had median arcuate ligament syndrome. She had a release and had a lot of scar tissue in the area, had a couple ethanol blocks that really faded for her fairly quickly, and she found us and we're able to do a celiac cryo for her. And so that's some of the stuff we're doing for the non-cancer related type pain. For the cancer-related stuff, we're doing a lot of celiac, plexus cryoneurolysis, splanchnics, intercostal for tumor or lung cancer, pudendal, obturator, and then a lot of just soft tissue mass, encroaching on nerves and things like that, sacral masses. We'll do, occasionally see some rectal pain where we're trying to figure out various targets, usually based on some type of soft tissue deposit in the pelvis encroaching on some nerve or certain areas.
I mean, that's incredibly varied. I have to Google some of these nerves. But, I would imagine in order to do this, you have to have a very good understanding of neurologic supply to these areas. I mean, I would imagine that's a challenge is for these patients that are just sent to you for undisclosed pain. How do you break down where this is coming from and what to target?
Yeah, that's a great question. I'll kind of defer back to my time, working with Dave Prologo. When I first sort of started learning about this stuff, I was at one of our peripheral hospitals that was kind of a sister hospital to the one that he worked at. And, someone called one day and said, "Hey, I've got a patient with abdominal pain. Can you do one of those ablations that you guys do?" And I said, "Well, hold on, let me call you back." And I called Dave and I said, "Hey, somebody's calling me about doing some type of nerve ablation. What is that? What do I tell him?" He said, "Well, call him back and tell him yes, and then call me back." And
that's
so
awesome.
I would get a lot of these calls and he would sort of walk me through, how to treat these patients and sort of an algorithm of really how to work this up. And one thing I learned was that the procedures, as interventional radiologists, the procedures, once you figure out what you're supposed to do, are really quite easy.
Yeah.
I mean, you're talking about CT guidance, placing a needle to a certain part of the body and turning a switch on and freezing it. And I mean, we do that all day for biopsies and drain placements. I mean, we can target anything. And so what I learned, and to kind of answer your question, is that the hardest part of this is really just trying to figure out what to target. And if your patients or anything like mine, you never get a straight story or a clear history. It's do you have pain? And the answer is yes. And you say, where is it? And they say, it's everywhere. It's all over. I feel it all the time. It's really one of these mysteries you've got to break down and try to understand exactly, where this pain generator is in the body, how you can target it, what nerve, are we talking about? And so what I'm still learning is sort of the art of trying to work these patients up.
Yeah.
And that to me is really the hardest part, because you rarely get a history of like straight up pudendal neuralgia where someone comes in and just gives you the textbook answer and you're like, oh, that's pudendal neuralgia. It really took a lot of learning how to talk to patients and sort of how to understand, how to interpret what kind of pain they're really in. And a lot of times they're not going to tell you. You've got to sort of, read their body movement and sort of how they're, are they just in bed bound and lying? Is the pain sharp? Is it tingling? Is it radiating? Is it exacerbated by certain things? It may not tell you that. A lot of times you've got to look to ancillary history from family or try to understand what their baseline was or, what they were doing before some of these pain syndromes happened. And so a lot of it is just in the workup. I think once you figure that out, the procedure part is really not that hard.
You talk about the pain like tingling or radiating. Why does that matter? Does it just help you localize, where it's coming from?
Yeah, I mean, and there are different types of pain, whether it's neuropathic or nociceptive, or if it's more autonomic, or I think that can really help you isolate if nerve is potentially involved. Especially with some of these low back pain, joint pain, some of these non-cancer related things where there can be so many etiologies of pain that is not necessarily just a nerve. I think too, when sort of working these patients up, one thing I've learned over time is really trying to calibrate expectations as well, because, pain's a really vulnerable and hard area to work. And these patients are really, they're desperate for a solution. And, if you come in there and you say, I can help you, you've got to be careful sometimes to say,
Totally.
I'm not sure I can take your pain to a 0 out of a 10. I want to, and I'm going to try. But, the reality is if you're a 10 out of a 10 and I can get you to a 5 or a 6, that's a huge win.
Yeah.
And, if we can get you even lower, that's just a bonus. But I think really trying to calibrate expectations and just being, forthcoming with the patient, depending on what you're treating, goes a long way.
Man, I think that's such a great point. And I think that for me is probably the biggest challenge. Not putting the needle in. It's setting expectations when I am, still kind of learning about this myself. I mean, this isn't an old established intervention, cryoneurolysis. And, it was hard to think back to the first time I did one for pudendal neuralgia. And I just had to be very honest. Like, I don't know, how long this is going to take, how long it's going to last, but I know that there's good data for this and we should give it a shot.
Yeah, absolutely. And that's the thing, we're still trying to generate data. And, I think we were talking about it earlier, we do a lot of cases. I'm not really a data guy. I'm not the guy out there doing the research. I'm not the innovator. Those are the Prologos of the world, right. And the Jack Jennings, Sean Tuddens, the Doug Beals of the world, who are amazing. Those are the leaders and the innovators. And, I'm just a guy out here doing cases. And so, but, the more you do, you learn a lot. And I, anecdotally feel like we've helped a lot of people. And, the research is so important because I think we need to get these things validated and approved and have insurance on board and really make sure that we can, keep offering these procedures
Absolutely.
To people that need them. So I'm totally on board with the concept that, we need that research. And, but it's a challenge when people ask, well, I Googled this and really there wasn't a lot out there. I'm not sure what cryoablation of the nerve is and, what are the outcomes and how long is this going to last? And, what are the complications? And so those can be challenging questions because we're still learning that.
Yeah. But I've also found that, this is a subset of patients, the ones that are in bad pain that are the most desperate to have improvement. They're like, look, you got something new, fuck it, let's try it. And it does make it a little bit easier, one element of that conversation.
It is. It is. And, pain, it's just, there's so many people out there that have it. It really, there is a need for, I think, what we can offer. And, the whole, there's a lot of talk out there about the opioid crisis, and it's real. I mean, we have so many patients that are just hooked to opioids and really they're maxed out on their doses. You see them in the hospital, they're just gorked out. It's miserable. I mean, just this guy just treated yesterday, sad story, 45-year-old guy with metastatic pancreatic cancer. I mean, 45. And just the nicest person. He was, very functional, still functional, and was just completely gorked out on narcotics and really just, could barely stay awake, but still had a lot of pain. And it's terminal, and he wants to spend time with his family, and he wants his remaining time to be, as meaningful as possible. And so we fortunately were able to do this case. I saw him this morning when I was in hospital, and he's actually doing really great. And I mean, the response has been really good for just less than 24 hours, which we can talk about a little bit later, sort of, expectations of how people respond post cryoneurolysis. But he's very happy, and he's actually being discharged later this afternoon. And so the hope is he can just go home, be with his family, not be completely maxed out on opioids to where he has some meaningful time left.
Yeah, I mean, when it works, it's the most rewarding thing you've done in a month. I mean, I had a similar guy, young guy with metastatic cancer, this terrible sacral metastasis that nobody could do anything for. Cryoablated it. He did very well, and he died. Not from that. I mean, he died from his cancer probably like 4 or 5 months later. His family put me in his obituary. I mean, it was an incredible thing. It worked so well. So, Aron, why cryo? We've got different ways to treat pain. We've got different ablation technologies. We've got chemical ablation. Why cryo?
Yeah, good question, Mike. It's, cryo was something I, again, was really introduced to, especially with regard to pain when I was at Emory and kind of working with Dr. Prologo. We had cryoed other things, renal masses, other soft tissue tumors. So I was familiar with the technology, but I really didn't understand or know the concept with regard why for pain. And of course, there's been a lot of talk on prior podcasts about sort of the pathophysiology of cryo with regard to nerves. You get this whole Sunderland 2 type injury, and really the premise is not just to turn off pain signals, but to induced this whole Wallerian degeneration and neuroregeneration, which was a concept I was not familiar with. And
Same.
so the thought is, not only are we helping the pain on the front end, but there's that potential to create a brand new nerve that essentially didn't have that injury prior to. And so does that create, longer duration of relief? Is that really going to give just a more durable outcome? And I think that's what's really being studied, especially when comparing to other, neurolysis modalities, ethanol, other chemicals, RF ablation, things like that. We've tried to sort of figure out how you can do some studies with the knee, for instance, comparing, say, RF to cryo, and that's not really been done to my knowledge as of yet. But, the thought with the knee, for instance, again, is that you're potentially creating a longer duration of relief. Now, we don't necessarily have that validated yet, but I think that's the thought. And so cryo, for other reasons, it's, being able to see and visualize the ice ball. I think for certain areas, it can be a little more gentle on adjacent structures, more controlled as well. I think you can titrate your ice. You can kind of see if it's getting to an area that is not safe, then you've got the ability to halt that and control that. So there are a lot of advantages and that I think are important. And then even coverage, ablation zone coverage, I think is especially with regard to nerves and single probe usage. So those are some of the things that I think are interesting and important about cryo that I learned that could potentially be advantageous.
Aron, in what circumstances for cryoneurolysis do you do a block first? And if you do it the same day, or do you do it and then bring them back for the neurolysis?
Yeah, good question. And I know it's probably been talked about before on some other podcasts, but we'll just say, for instance, for non-cancer related pain, almost always I'm doing a block prior to. If it is for, say, the genicular nerve, again, kind of going to our algorithm of sort of how we treat knee pain, a lot of patients we're triaging with the block. And, unless they come to us with, recurrent hemarthrosis or things like that, we're kind of going to the block first to see if that works. And if it does, then we're going to the ablation. Same with the pudendal and, intercostal and things like that. It's kind of a dress rehearsal for me and for the patient to sort of understand, not only are we trying to test if this is diagnostic, if this is truly your pain generator, but it's going to kind of give you a sense too of what we're doing. And if we're going to commit to the cryo, it gives me a little time. These are usually not urgent cases, so it gives me a little time to coach them and get expectations in order, and also just to make sure that before doing a cryo, it's going to work. So I really do block most of the non-cancer pain syndromes if I can.
Yeah, I'm with you. You talk about setting expectations. Let's take, the pudendal, for example. What do you tell them in terms of what to expect after, including when you expect them to have pain relief and how long you expect it to last?
It's a good question. And again, I think that, depending on the etiology of the syndrome and kind of, how long it's been going on for, what the inciting injury would have been, I basically tell them, I think this is what you have. And sometimes if it's not clear, then, I make that, I'm upfront and I say, your symptoms seem to point to pudendal neuralgia. You've got some other ones that don't quite add up, but, let's try this block first. And if it is in fact pudendal neuralgia and we do this block, and I generally do these with CT guidance, because I know exactly what I'm targeting and if I'm hitting that target. And I tell them, if basically you get relief from this block, and it won't be subtle. It's going to be, you're going to know, and you're going to be able to tell me that this was a positive response. And if that's the case, then this is the target. This is the pain generator, and you do have pudendal neuralgia. And when we do the cryo, I generally try to counsel them on what I think, and this is after a positive block. I say that the cryo is going to help you. Here's what I think could happen afterward, for cryoneurolysis in particular, and I think, again, this is kind of alluding back to some of the teachings from Prologo. He talks about sort of his 3 buckets of responders. And I've had a similar experience, in my practice, where you get this first set of responders where they almost get immediate relief, or it's almost like the day after. I did an intercostal cryo recently, and within 24 hours had complete pain relief. And so that maybe is that first, bucket of responders. And then you get kind of this second area where they respond, but it may take, 2 or 3 days. May have, some inflammation, a little bit worse pain, what have you. But in general, it's very mild and short-lived, and they'll get some good pain relief. And, sometimes that could be from a tumor deposit or, encroaching on a nerve, and you kind of release it. And there's that third bucket, which I've had a couple experiences recently where you cryo a nerve, and for weeks and sometimes up to a month, they actually have worse pain.
Yeah.
And I had a lady that I treated for pudendal neuralgia that was one of these, a benign etiology, very athletic. She had done a lot of horseback riding and various things like that. And so we did the block, and, literally like 6 hours after the block, completely pain-free.
Yeah.
Just, it was like a miracle for her, and she had been hurting for years. But, her story was a little bit ambiguous and wasn't sort of this clear cut. She had some lower back pain, she had some other pain that didn't quite fit the bill, but she had enough of the criteria that we thought pudendal was a good option. So after the block, we did the cryo, and I told her, I this is what we might expect. The pain may not be instant. I kind of gave her that whole responder speech, and you could be in one of these areas. Long story short, for about 3 weeks, really about 3 or 4 weeks after the cryo, she had, just almost worse than pudendal neuralgia. I mean, she had this exquisite sensitivity, this vulvodynia. It almost felt like she had like a sunburn around her whole perineal region. And what I learned there and from, various other cases is that you really have to see them in clinic and reassure them. And, I said, look, these, you're kind of in this third bucket here of what I think. And I, my hope and what I know is going to happen is that, this nerve's going to go through a process where there's a lot of inflammation, there's a lot of infiltration, and you've got this worse pain, but it's going to get better. And, after a month or so, a lot of that inflammation is going to subside, and, you get into this sort of Wallerian degeneration part, and then this nerve is going to grow back. And you're, the hope is after some period of time, and it could be weeks to months, you're going to feel better. But now it's a little bit of a long game. And, that's hard for people who were previously athletic and very active. And, all of a sudden, they're like, what have we done here?
Yeah. My first one I ever did was a very similar story and a very similar result. And I'm the one that needed the reassurance. Like, I called Prologo in a near panic. I'm like, what happened? He's like, it's fine. Just cool off.
Yeah. And I think that's another testament to cryoablation. Really, it's got that profile of creating, a nerve injury that's reversible, and that's the intention. And so, there's some reassurance there. And again, I think it's just counseling the patient, making sure they understand, I'm going to get you through this, and it's going to take some time, and that can be a challenge. I had one younger lady I did a stellate cryoneurolysis on. And again, we did the block. And she had left-sided complex regional pain syndrome.
Uh-huh.
And we don't do a high volume of these, so every time I do them, it just, kind of like, all right, we're going to do this. But she did great on the block, and then brought her back and did the cryo. And a lot of the symptoms she was having with the complex regional pain went away and did great. But I think what happened is my ice ball potentially clipped kind of an inferior C7 cervical nerve root.
Mm-hmm.
And so she got these motor deficits in her left arm that, she barely lift her arm. And that was terrifying. I was like, oh gosh,
yeah.
what's happened here? And so it took it took a good 6 months to get her through that to where she's doing great now. In fact, she's super happy because now, the arm is essentially repaired and all the symptoms she was having from the complex regional pain are essentially gone. But, you get these cases where these things happen and you've got to really work through it and reassure them and let them know, these motor components will come back. And so I found that to be, a learning process and a challenge that we do a lot of other types of procedures, uterine fibroids and various things where or even with kyphoplasty, things like that, where you just, when you're done, you're done. And you don't necessarily have to continue kind of coaching your patient through the process and reassuring them. So there's that sort of, labor intensive component sometimes of pain and pain intervention.
Absolutely. And I don't think this is something that I would have been able to handle before I had a clinic.
Yeah. It's been said, a million times over, but, the clinic it's really more, I used to think, well, you should have to have a clinic. That's what everyone says. And you got to see your patient. But more and more I understand why. And it's, I have the ability to schedule a patient weekly for follow-up if they're able to come and see me. And like having that freedom to do that, really, it's good for me. It's good for the patient. And I don't see patients every week like that. But if I have a patient that had sort of an adverse event like that I need to just make sure we get them through it, then, having a clinic is so pertinent to be able to do that.
Very much. And it's also helpful to have a clinic nurse who is used to handling these phone calls. It's like, you're all right, and, they're not panicked too. I've got a great clinic nurse.
Yeah. You probably know it. I mean, it takes a lot of education too, right? I mean, how much pain intervention did your clinic nurse sort of have? How much background did they have prior to seeing these patients? I mean,
none.
You probably
she was
had
a
to
urology nurse, and we took her.
I think there's a big learning curve with managing these patients, and like I said, doing the procedures is, once you figure that out, is the easy part.
Yeah. There is one procedure I'd like to go through in detail, and that's how you're doing the celiac cryoneurolysis. First of all, what has your experience been like comparing cryoneurolysis to chemical neurolysis for either benign or malignant, pain related to the celiac plexus?
Yeah, another great question. I have been fortunate enough to do quite a few celiacs, or unfortunate enough, I don't know. Either way.
Fortunate that you can do it. Yeah.
Right. But, I was doing all ethanol neurolysis when I first started doing these, and, even back in fellowship and shortly thereafter. And then when I started doing the cryo, when I came to Emory, learned a lot of different things. And so, one thing we found with ethanol is that, sometimes these patients would get this transient diarrhea, GI effect syndrome. And I remember I had this one older guy who was actually a friend of mine. It was his dad, and did pancreatic cancer, did an ethanol neurolysis, completely pain-free within 24 hours, did amazing. And then he had this horrific diarrhea syndrome for like 3 weeks.
3 weeks?
3 weeks. And he was hospitalized with it, and all his metabolites were deranged, and he was dehydrated and just was really sick from the diarrhea.
Yeah.
And the GI, they were putting on these triotide regimens and like all these crazy things. And that was a more dramatic presentation. But I would see, this kind of diarrhea phenomenon happen in, 30 to 40% of these patients. And when we started doing more cryo, we noticed, and we weren't having these GI side effects, but we were still getting, pain responders. And, we put a paper out in JVIR some years ago, kind of comparing the two and with that data in mind. And so, that was one sort of difference that I noticed. And, some of the other things with celiac, I often do mine with general anesthesia if I can, because, putting those needles in such a sensitive space, number one, it's just easier if you can have the patient asleep and not moving. Other things I started to notice, and with some consistency, is that especially for the metastatic cancer patients who were not always optimized. Electrolytes were off, they were dehydrated. You would do these cryos, and oftentimes, you'd get these sympathetic reactions where their blood pressures would drop. The systolic would drop, into the 60s and 70s, and then you would put them on a thaw, and potentially you were maybe close to the adrenal gland, or occasionally would get this sort of catecholamine effect where all of a sudden the systolic jumps and to 280, 290. And we were trying to do this with just an IR nurse and a blood pressure cuff, and we couldn't keep up. And so a lot of times, if I have the resource, I'll have anesthesia, we'll start an art line, and you can just monitor that blood pressure throughout. And so that's one way I try to do them, and just to sort of manage the blood pressure changes that we'll see with this.
Yeah, it makes a lot of sense too, just having such a tight control of the ablation zone. When I'm using ethanol, after I inject it, I almost don't want to look. Like, I almost don't want to scan it and see where it's gone, because it goes so much farther down than the celiac plexus. But targeting has got to be more of a challenge, I would think. I mean, it's a bigger needle than you're using for an ethanol neurolysis. How do you approach that? How many probes are you doing? Do you go anterior, posterior? Like, how do you do it?
Yeah, generally, I have these patients prone. I'm going posterior, sort of posterior bilateral pericurl, and essentially I'll use usually something like an ice rod or something that's got more of an oval, front to back type of morphology. And I tend to target the plexus. It's this 3-dimensional network that runs from the celiac axis to the SMA, and it sort of goes anterior around the aorta, and you kind of go posterior back into the splanchnics. When I'm targeting, I'm usually a little bit down closer towards the SMA, just for anatomic reasons. And, I'll get my 2 probes in, CT guidance. I kind of get the tips anteriorly sort of aligned with the aorta. What I'm hoping is that I'm getting sort of an anterior to posterior growth of the ice ball from the celiac plexus sort of back toward the splanchnics. And with CT, obviously, you can get a very precise and safe localization. Right. Where things to look for or your proximity to the adrenal gland. Obviously, sometimes there can be little intercostal or paraspinal arteries around that area. You just sometimes can see, and obviously want to try to avoid. Usually, you're not ablating back to the kidney, or there's not like bowel or other things in the way. So as far as any type of collateral issue, there's not a whole lot. And people will sometimes ask, well, if you're sort of nudged up against the aorta, do you ever worry about the ice hurting the aorta? And I tell them no. I mean, there's so much heat sink in these vessels that, I've had ice balls grow directly into the aorta, and it's just not going to hurt. Not going to
do anything.
That's generally my approach to these with the needle. I will say one thing I like about cryo over ethanol is, especially with soft tissue tumor, if you've got lymph nodes or infiltrate, if you've noticed with ethanol, sometimes you inject and it just kind of goes around the tumor, or gets absorbed into the tumor, or the tumor even boxes it out from the nerves. And so I think cryo has the advantage of really targeting the plexus, even in the event that you've got soft tissue kind of encroaching or encasing the area where the celiac plexus is.
Yeah. You mentioned for celiac plexus, when available, you're doing general anesthesia. Are you doing the majority of the other ones under moderate sedation?
I am. The majority is under moderate sedation. And usually these are single probe peripheral nerves, quick, intercostals, pudendals, for the most part under moderate sedation.
When you're doing the intercostals, do you worry about the ice ball being, right along the pleura?
I don't. I haven't had any issue, knock on wood, with any pleural injury. It's a relatively safe space. Occasionally, you've got to do maneuvers to protect the skin if you have a thinner patient or things like that. But I haven't, had any issue with the pleura itself.
For the various pain interventions that you're doing with cryo and other modalities, are there any circumstances where you look at it and just like cryo is not appropriate here?
Not sure that I necessarily think that for cryo specifically, but certainly for ablation in general. Obviously with with nerves that have a heavy motor component, or potentially nerves that are in areas where there could be some other collateral damage issues next to bowel, or things that aren't, as forgiving toward even cryo, I tend to think twice about doing that. For instance, superior hypogastric blocks, I used to do a lot of those when I was, for UFE. I don't do that as much now, but
Me either.
never really cryoed that space. I had done a couple where I had to take this sort of very angulated posterior approach to even get to that area, but the geography of that bundle is just difficult to get to with cryoprobes. And so, some of it too is just anatomically, is it safe for me to get there?
So do you use the same general freeze thaw cycle for each of these?
For the larger nerve bundle, say like celiac plexus, I am still generally doing somewhere around a 10-5, 10-5, with passive thaws. Now, if we're doing pudendals, I do kind of subscribe to that sort of A3-3-3 pattern that Dr. Prologo described, and then things for geniculars, generally just doing some type of single freeze and thaw. So anywhere from 8 or 9 minute freeze with a 5-minute passive thaw. For the most part, for smaller peripheral nerves, we're just talking a single freeze, single thaw.
For the geniculars, how many probes are you doing?
I'm doing currently 3 probes. We don't do the suprapatellar area. We're basically just doing the superior, medial, lateral, and inferior medial nerves.
Do you do them all at once or one at a time? My problem when I'm doing them is that if I'm doing multiple probes and it's not a particularly heavy patient, I have to have somebody hold the probe in place. I can't hold all of them at the same time because they all kind of veer off a little bit.
Yeah, I do all 3 at the same time. And really that shorter ice sphere probe that Boston Scientific makes has been really useful for things like the knee and areas, because it's only about 10 centimeters. And so, it's perfect for that space because you don't have the shaft that's sort of tilting your probe over and torquing it. And then, it's like impossible to sort of, get your cord situated. So those are really good for the intercostals and geniculars. And occasionally when we're doing things like the phantom limb or anything in the leg, those are really useful for that type of real estate where you just don't have a lot of skin purchase into the tissue.
Got it. Aron, that's about all I got. Is there anything else that I didn't go over that you want to talk about?
I think the only other thing, we had sort of talked about it earlier in the podcast about just, some of the cases we do in the OBL versus the hospital. And I thought that would be an interesting thing to discuss. We do a lot of different things in our OBL, from PAD to Y90 to prostate, genicular artery, UFE. I mean, we do everything, and we do various ablations, including pain. Earlier on, we were doing more cryoneurolysis in the OBL, and I think one of the challenges so far in that landscape with cryo and pain in particular is we're still navigating the insurance and reimbursement and things like that. I know there's a lot of leadership out there with SIR and various committees and pain committees trying to get, some of these codes forwarded on and approved and get these things validated so that we can essentially get paid to do this work. But when we were doing some of these cases, for instance, I about 3 weeks ago did a pudendal in our OBL. Occasionally we were doing a lot more geniculars. We'll do an intercostal here and there, but one of the main issues we've been having with that is really just reimbursement. But that aside, it is so nice to do them in the OBL. We actually have a setup where we have CRNAs and we do propofol for our patients. And so it's really conducive to doing these types of procedures. We have a GE mobile C-arm that does cone beam. And so, it's very efficient. We're able to cone beam our prostates and, we'll even do some of our Y90 mappings, things like that. But, when you cone beam an extremity or pelvis or anything like that, you get really good visualization of bone and muscle. And so we were able to do some of these here. And so that's really nice for the patient. And it really just makes, especially for, patients with pain and cancer and various things, being able to not go to the hospital, being able to just pull up into a parking lot, check in, and be on the table within 30 minutes and asleep, and then, get your procedure and then wake up in this nice luxurious recovery room where you have a single nurse taking care of you and you're watching TV and eating and it's just a great experience.
God, you guys are so fancy. Like, what a great setup. Like cone beam in your OBL and Y90 in your OBL, and I'm a little jealous.
Yeah, no, we were able to do a lot of cool procedures here, and pain really is just a small facet of that. And two, with the cancer patients, with a lot of our PAD patients, things like that. I mean, pain really just goes hand in hand with a lot of our other patient populations. It's just such a great service line because we have, so many patients that are in need of it. And a lot of patients who come in for other things sort of figure out that we're doing some pain interventions, and we end up offering services to these patients who otherwise didn't know there was something out there for them.
Yeah, that's awesome. All right, man. Well, thanks for sharing your Saturday. I hope you have a quiet remainder of your call weekend.
Well, I appreciate it, Michael. Thanks for having me on and for taking time from your call experience to chat with me. So
it is an experience.
Yeah. Speaking of which, I'm getting paged as we speak. So
I hope it's nothing.
Me too.
All right, buddy.
Well, I appreciate it, man. It's really good to talk to you. So.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jimmy Kennebrew.
Thanks again, and see you next time.